Hi, my name is Sam Harris. I'm a behavior analyst. I wanted to talk briefly today about autism and self injury, or more specifically, treating self injury behaviors in individuals who have an autism diagnosis. Um, the range of behaviors that we might see varies pretty widely. Sometimes we're just talking about superficial harm to the skin, like let's say somebody scratching their forearms with their fingernails or a found object, all the way to individuals who are literally blinding themselves by blows to the eye or maybe giving themselves repeated concussions. So there's a wide range of forms it can take, and so the interventions that we use are equally wide. There really isn't one simple boilerplate, like if you do this one intervention, it's going to work in all cases. The interventions that we use can range everywhere from just ignore it, and sometimes that's effective under some circumstances, to using physical restraints and blocking the behavior, or even having punishment procedures in severe cases. So there's a wide range of interventions depending on the function. I guess in that way, treating individuals with autism when there's self injury is kind of the same as treating it with anybody else, in that we start with trying to understand what is the function, why is this occurring. They've got a reason, they're accomplishing something. We just need to figure out, okay, what do you believe you're getting out of this? And then we work from there in coming up with some interventions. Because if we get the function wrong, if we misidentify what function is being served, the interventions, the treatment we have is simply not going to work. To give you some idea of range, I had one client who would frequently overdose on Tylenol and go to the hospital. And he was verbal, and we looked at the circumstances and talked to him, and he was able to tell us why. Well, I do it for two reasons. One is, when I take all that Tylenol, I feel good, because there's a certain subcategory of people who feel euphoria when they take Tylenol. And two, when I go to the hospital, they keep me there for 3 days and give me a lot of meds that make me feel really good, and I can't get those anyplace else. Okay, so we had one set of interventions you got to use in a case like that. There's another case where I had a client where he would bang his head on the wall, and he had a helmet, a protective helmet, because this was so frequent. And then when he could, he would take the helmet off and then go back to banging his head. So that one kind of makes you look at, okay, the function appears to be sensory seeking in this case. So you can see how those two different cases are going to take entirely different types of interventions to address them. One thing that you'll see more often in individuals with autism compared to other disabilities is that sensory seeking aspect, what we call automatic, a sensory seeking aspect. There is reason in research to believe that individuals with autism are actually processing the pain signals differently, which would explain why many individuals on the spectrum are hyposensitive or less sensitive to some types of pain. So sometimes, like one subcategory of individuals with those self-harm behaviors are actually treated with opioid blockers, just like you would use in treatment of drug abuse, because blocking those opioids stops those natural signals from their body that make them feel good after minor injury. Think of that runner's high that some runners get when they say they're out there exercising hard. That same effect is seen in some individuals with autism who are harming themselves. So if that were the function, we would have to approach it another way again. So some of the questions that I would ask stepping into a situation, you say, hey, we've got this case of self-harm. I'm asking severity. Is this superficial, where there isn't actually medical injury to an individual? Or is this quite serious, where we're talking about multiple concussions, the potential death in severe cases? So what severity? Because that kind of lets me know how extreme, how quick are our interventions going to need to be. Does it occur alone? Or are other people always in the room when it happens? When there's self-injury, does the client make an effort to hide it? Or do they make sure somebody knows pretty soon afterwards? Like, what are the antecedents? What's happening right before that case of self-injury? And also a cognitive ability. When we see those individuals with average or above cognitive ability, we're kind of looking at one set of functions, and individuals of very low cognitive ability often have a different set of functions that are more likely. So you use all of those questions to start to think, okay, where should I be looking for the function? And start to develop a good theory about what's going on, what's the function being served, so that then we can come up with an intervention to meet that function, but obviously in a way that's not going to injure the client, a way that's not self-injurious. I wish that I had an easy answer. Like, hey, always use this intervention and it's going to help the client. But it's not really like that. It's actually very complex. But I want to affirm the idea of, man, when you hear that somebody's got self injury, prioritize it. It's a big deal, it's very important. It's potentially medically dangerous or even deadly to the client. It's potentially distressing emotionally to the client. It is definitely distressing to caregivers, especially to parents when you see your own child injuring themselves. So, whenever you see a self injury come up in a case, that needs to be one of the targets. That needs to be one of the things we address. We got to find a solution to this for everybody's sake. So I don't know if I had any really good answers, but this is some questions and things to think about as you address the behavior. So thank you for your time, and God bless.